All right, let's break down this case in a straightforward and professional manner, just like we do on Radiology Made Easy. Looking at this coronal reformatted CT image of the abdomen, the first thing I notice is an abnormal appearance in the right lower quadrant. There's high attenuation material in the cecum, transverse, and descending colon, which looks like residual barium from a previous gastrointestinal contrast study. The wall of the terminal ileum is thickened, and there's streaky mesenteric fat around it, indicating inflammation. It's interesting how the terminal ileum looks like it's adhering to nearby bowel loops, creating this acute angle and cloverleaf appearance in the right pelvis. This suggests a scarring process. In addition, there are enlarged lymph nodes along the ileocolic vessels in the mesentery. These inflammatory changes make me think of Crohn's disease, especially with the involvement of the terminal ileum and signs pointing to an enteroenteric fistula between the distal small bowel loops. If the patient has a known history of inflammatory bowel disease, this diagnosis fits well. If not, I'd definitely communicate these findings to the gastroenterology team, who might consider endoscopy and biopsy for further evaluation. Now let's talk about fistulas in the gastrointestinal tract, which can be tricky. Often, the actual fistula tract isn't visible, but we infer its presence through other features. For instance, if we see barium from a small bowel study in the sigmoid colon before the rest of the large bowel, it hints at an enterocolic fistula. Similarly, gas bubbles in the bladder on CT, along with abnormal sigmoid colon next to the bladder, suggest a colovesical fistula. Getting a precise delineation of fistula tracts and identifying the underlying cause, whether benign or malignant, can be challenging. Cross-sectional imaging, barium studies, and endoscopy are crucial here, and sometimes a biopsy might be needed to clarify things. Gastrointestinal tract fistulation comes in various forms, with the most common being enteroenteric fistulas caused by Crohn's disease. However, any adjacent luminal structures can potentially form a fistula. If Crohn's isn't the underlying issue, other chronic inflammatory diseases or even malignancies might be the cause. So, in summary, these CT findings strongly suggest Crohn's disease with a potential enteroenteric fistula. I'll make sure to relay this information clearly to the treating team for further management. Thanks for joining me on this diagnostic journey. Remember to subscribe to Radiology Made Easy for more insights.